Hello, good evening, Facebook. I thank you for joining us this evening. I'm very excited to have another TIF Talk this week. We have some special guests with us today. We have Dr. Amar Thosani and also Dr. Albert Amini. Thank you both for being here with us tonight. We really appreciate it.
Thank you for having us.
You're welcome. Thank you.
So just to give you a little background, my name is Andrea Millers and I'm with Endogastric Solutions. And this is a live event, so if you want to ask your questions, please go ahead and type them in the comment section, and we will do our best to answer any questions that you have for any of the doctors today. So let me tell you a little bit about our guest speakers today. We have Dr. Amar Thosani. He is a board-certified gastroenterologist and a therapeutic endoscopist and has over 20 years of experience in the medical field. His practice focuses on complex endoscopic procedures of the biliary system, pancreas, gastrointestinal cancers, and esophageal disorders. He specializes in minimally invasive approaches to many gastrointestinal diseases that previously required invasive surgeries. Dr. Thosani is currently the Director of Advanced Endoscopy at the hospital where he works in Scottsdale, Arizona. For joining us, Dr. Thosani. In addition to that, we have Dr. Albert Amini. Dr. Albert Amini is the founder and president of Arizona Premier Surgery and a board-certified general surgeon with fellowship training in minimally invasive surgery for the liver, pancreas, and bile ducts. Dr. Amini also travels abroad to perform surgeries on underserved patients in the Dominican Republic and is published in a multitude of papers and presentations. So I'm really excited today because Dr. Thosani and Amini are both partners, and we often talk about hiatal hernia repair and the TIF procedure, and that's exactly what these two physicians do for patients. So we'll have a unique conversation about how that works. But first, let's go ahead and start talking a little bit more about what is GERD, what kinds of symptoms could potential patients be feeling, what are the types of things that they could, are they taking medication or whatnot? So talk to us a little bit more about what is GERD.
Sure. So GERD or gastroesophageal reflux disease is basically where the contents, mainly gastric acid that's produced in the stomach, refluxes up through what's called the lower esophageal sphincter into the esophagus. And because of the acidic nature of the contents in the stomach, patients, when that reflux material comes up into the esophagus, the acid in there causes symptoms when it touches the lining of the esophagus, and this is often have symptoms such as pain or burning. It's a very common condition. I believe there's about 60 million prescriptions for acid-reducing medications prescribed every year in the U.S. So it's a very common problem, and it's one that's the majority of people treat medically right now, although we don't think that's necessarily the best option.
Perfect, thank you. Can you talk to us a little bit more about like typical symptoms versus atypical symptoms? There's a lot of times patients say they feel like they're having a heart attack, or they go into the ER because they think they're having a heart attack and come to find out they're having, severe acid reflux. Can you talk about a little bit of that?
Absolutely. So the typical symptoms of acid reflux are, again, when that acidic contents of the stomach come up into the esophagus. Mainly, the main thing people complain of typically is burning. They feel like your chest is on fire. A lot of times, what can happen in addition to burning is that they can also have a pressure feeling, and that's where oftentimes bad acid reflux is mistaken for someone having a heart attack, and if they have an acute reflux episode and it causes burning and that pressure, oftentimes people go to the emergency room thinking it's their heart. Those are really the main typical symptoms of acid reflux, but there's a lot of atypical symptoms. I'm sorry, just to go back to the typical symptoms, another symptom is regurgitation, where you feel like you're almost vomiting material up, and then it comes up to the back of the throat and you swallow it. There's also a condition called sour rash, where when acid comes up, it causes a reflux, and your mouth fills with saliva, which is a common condition of acid reflux. Again, very typical. Some of the atypical symptoms of acid reflux, which a lot of people suffer from, is chronic coughing, especially when people lay down at night and they don't have that good barrier to preventing the acid from coming up. What actually happens is that acid travels up to the esophagus, and it goes down into their windpipe. And it can irritate the vocal cords in the windpipe, and people can have a chronic cough, and it can be a very debilitating condition, which they seek out medical care for this cough, and a lot of times it's due to acid reflux.
And I think a big part of the atypical symptoms is the kind of misconception of how the medications work. A lot of people think, oh, I'm taking a reflux medication, so that's improving my sphincter muscle, or I'm getting less reflux, or different ways that they think it's reducing the reflux. And what it's actually doing is just kind of decreasing the acid and decreasing kind of the acidity of the reflux, and that's why the burning is less and some of the symptoms are better, but you're still actively refluxing. It hasn't decreased the amount you reflux. And so that's why they say, hey, my pain is better, or I'm not having as much discomfort as I used to be having, but they're still can't lay flat, having trouble breathing, having cough, having other issues. And I think that's a common misconception with how they're being managed with medically with the pills instead.
Yeah, that's a really good point. So talk to us a little bit about, what do you normally have patients do to manage their GERD? Kind of like initially when they come in, you're talking about medical therapy. Are there different lifestyle modifications that they need to make, or, stay away from certain foods, change their exercise program or whatnot? What do you guys normally tell patients to do?
I think we normally tell patients to do the standard things. One is I think one big thing is to eat more frequently in smaller quantities. I think when you eat infrequently in large quantities, it just adds a lot of food in your stomach, and it kind of overburdens your stomach, and then you can reflux more. So I think that's one big thing. I'll be honest. I'm not so much of a believer of changing what you eat. I know a lot of people say don't drink coffee, or don't do this, or avoid spicy foods. But when you actually think about what's happening from a physiological standpoint, the pH of the stomach, which is the acid content, is about 1, which is just about as low as you can go. How much are we really changing that pH by avoiding certain foods? It's an anatomic problem, not so much what we're eating. But definitely some patients do feel better when they stay away from certain foods, spicy foods or caffeinated foods, or things that can cause a lot of bubbles or a lot of gas in the stomach. So we start with that. Another big thing is when they're sleeping, is to prop their head up. And again, that's just because of that's because of gravity. Basically, if you lie down flat and your sphincter is not holding the acid down into the stomach, that the stomach contents just kind of have a easier time flowing up into the esophagus. So if they prop their head up, it can make them feel better. And then I think another big thing is to not eat so late at night, because you want, while you're upright, when we're awake, we're normally upright, whether sitting or standing. You want the food that you eat to be passed through your stomach. If you eat late at night, then lie down right away. It's just a lot more contents that you can have to reflux up. So those are the main things that I normally start with.
Okay, fantastic. We do have a couple of questions that have come up, so I'm just going to ask them. Rajesh says hi to all of us, but he's also asking, doctors, is regurgitation an advanced state of acid reflux?
No, I don't believe it's an advanced state of acid reflux. It's just what's actually happening it's that where the contents in the stomach are coming up into the esophagus. That's what the regurgitation is. It just depends how high it's coming up, and then when there's a big bolus of it, or if it comes up much higher, that's the regurgitation symptom.
So it's just part of the normal, not normal, I should say.
It's part of
part of the reflux, normal reflux. Okay. So what options are available right now to treat GERD? I know, Dr. Amini, you talked about medical therapy, and maybe you can talk about the different types of medications, right? There's different classifications, and then also what other procedures are available for managing or treating GERD.
Yeah, I'll take the medical, and I'll let Dr. Amini talk about surgical issues. So, so the mainstay of treatment of GERD currently in today's date is what's called proton pump inhibitors, which are a class of medications that we all hear about, whether it's Nexium or Prilosec or Dexilant or omeprazole. There's a whole host of medications out there that are known as proton pump inhibitors, and what they do is when you take this medication, it shuts off the pump that secretes the hydrogen that combines with the chloride to make hydrochloric acid, and it turns that pump off, and it turns it off for a certain period of time, whether it's 12 hours or 18 hours. And basically what it's doing in the stomach, it stops the secretion of acid into the stomach. And it doesn't 100% stop all the acid. It only blocks a certain number of the pumps, whether it's 30% or 50%, but it effectively lowers the amount of acid in the stomach, thereby increasing the pH. That's really the mainstay of treatment currently with medications now for acid reflux. And there's lots of other medications out there. Previously, or there's coating medications like famotidine. There's different types of medications like H2 blockers that like Tagamet that people have taken in the past. And then there's a class of medications that was actually just recently taken off the market because of potential carcinogenic compounds within the medication. Within the capsule, so that's been an issue, but I'd still say currently the mainstay of medical treatment are these proton pump inhibitors.
Okay.
Yes, I think if your symptoms are mild, you're probably seeing your primary care doctor or picking up some medications at the pharmacy, and really it's just adjusting your diet the way that Dr. Thosani said, starting the medications, either the H2 blockers or the Tums or the PPIs, like Dr. Thosani said. And I think, if people have mild symptoms, they're probably going to do okay on that, to be honest with you. They're still refluxing, and that's the main key that we have to let people know. You're still refluxing. And so if there's atypical symptoms or the symptoms aren't getting better, it's because you're still refluxing. You just feel better with those medications. And then after, kind of they get through that gamut of stuff, then they're really, moving on to GI or surgery and saying, hey, I've tried everything. I've tried the diet, even the weight loss, whatever it is, and I'm still feeling miserable at night. I'm still not comfortable. I can't lay flat. It's affecting my quality of life. It's starting to, I don't want to take these medications for forever. A lot of these medications have side effects with long-term use, and so then they're going to a gastroenterologist or a surgeon and saying, hey, I want to take this to the kind of the next level. What do you have for me? And I think at that point, before we really get into treatment, we really have to get a better idea of their anatomy. And so that's when we do a workup, and that's where we want to see, well, is their esophagus normal? Do they have damage to the esophagus from all that reflux? There's Barrett's esophagus, where you start to get changes in the esophagus, and that can turn into cancer. So we want to rule that out. We want to rule out any other issues that's causing all their symptoms. And then we get other diagnostic tests, like barium swallows and manometry, and we want to test their anatomy to see, okay, is their sphincter muscle not working well? Are they actively refluxing? How much are they refluxing? And then that's also when we get the endoscopy by Dr. Thosani and scans to see, well, do they have a hiatal hernia? A lot of these are associated with a hernia, and the surgery or the treatment can change dramatically if they have a hernia. So they get a much bigger workup, and PCPs just don't feel comfortable doing that, and really aren't there to do that, to be honest with you. And so if the symptoms, have progressed to the point where the meds aren't working, the diet's not working, the non-surgical is not working, you really got to be in with a GI doctor or a surgeon. You got to get a workup. And then that's when we kind of start talking about some of the treatments, which we can go into, or if there's any other questions.
Yeah, no, I'm glad you talked about that, because a lot of the questions patients have are, what does my workup look like? And what are all the different tests that I need to take or do to determine if I'm even a candidate for any type of procedure? So I'm glad you brought that up.
A lot of patients honestly have been suffering for a long time. And when they come, they're like, oh yeah, 7 years ago, they told me that I had reflux and some changes and a small hernia, but they told me to change my diet and do this. And it's been 7 years and I'm not any better. And it's because they're not going to be better. It's not improving their sphincter muscle. It's not improving all they're doing is just controlling some of their symptoms. And so a lot of them come and they already have an idea about hernias. They already have an idea about the sphincter. They already have an idea about reflux, but they haven't really had, full workup or an explanation of any other option other than diet and medical. And so then they show up and they say, okay, well, I've been suffering now for X amount of years. Somebody got me here, or something got me here, and now I want to see what else to do. And that's when usually, Dr. Thosani does an endoscopy and just kind of clarifies their anatomy, clarifies their reflux, their esophagus, any other abnormalities, and then they come to me, and we usually get a barium swallow to look at how they swallow, how much they're refluxing, maybe a scan to see how big or small a hernia is. And then after pretty quickly after that, we start to talk about, okay, well, these are non-medical management, either minimally invasive thing, TIF like Dr. Thosani can do, or a combo like we can do together, or maybe a bigger surgery.
Yeah. Thank you for explaining that. We have quite a few questions, so I'm going to try and go through those, and then we'll go into more about the different options, treatment options, if you will. So we've got a question: how long should someone take PPIs before considering a specialist's opinion? I think you just kind of talked about that regarding other or long-term treatment options.
Yeah, it's if you actually look at the literature for all the PPIs, and it's not just one of them, it's actually all of them. When you look at the literature and what the drug companies recommend, they usually recommend a 14-day course, right? And then after that 14 days. But as we all know, people are on these PPIs for years and years and years. I mean, I've seen patients that have been on these medications for 15 years, and without the medications, they just can't. They're not comfortable. They have reflux and pain and regurgitation and and all the other symptoms that go along with acid reflux. And we didn't actually, I'll be honest, as a gastroenterologist, it's such a reflex that if someone has any symptoms that sound like reflux, just to give them a PPI, it's such an easy thing to do. And there's so many companies that have different PPIs in it. And it's honestly, it's a very easy way. I'm not saying the correct way, but it's an easy way to treat the problem. And if a patient goes to a gastroenterologist's office and complains about this, I can guarantee you they're going to come out with a script for a PPI. And some patients have been on this for so long. But I think in the past 4 to 5 years, a lot of data has come out that's actually questioning the long-term safety of these PPIs. And it's hard to tell what is 100% accurate because these are big population-based studies. But this PPI use has been linked to multiple different things. It's been linked to heart disease and Alzheimer's and kidney disease and decreased bone mineralization and decreased magnesium levels. And so there's a lot of other things. And I think I think they're all valid points, right? I mean, when you're on something that's altering the cell type in your body, when you're on these for long periods of times, there's potential for damage. So I think that's the one reason why people are trying to find other ways to treat the acid reflux. And in my opinion, if you look back. If you go back to the 1950s when Dr. Nissen actually invented this surgery, that's how people treated bad reflux, is actually surgical, fix the anatomy. And then, things have progressed with different medications and H2 blockers and PPIs. And that used to be a big surgery, a big open surgery, and people didn't like that. So then we went with the medications, and now we're going kind of back to, as our surgical and endoscopic techniques have gotten so much better, we're coming back to a role that we can actually fix the problem again and not just put a bandage on it. So that I think that's how the treatment of has changed.
Yeah, that's a really good point. And I saw an article, I think a month ago, about PPIs even being correlating with COVID too. So did you read that article?
Yeah. And again, I mean, it's so hard to that's the one thing about these studies. I feel like there's a lot of stuff written. I mean, there's some stuff that came out a couple of years ago that people on PPIs are at more risk of C. diff infection, and it's hard. And I definitely don't want to blame all these things on PPIs.
Right.
The fact that you're if you need a long-term medication. I mean, it's got to have some effects on the body, and I think all that data is in the preliminary stages, but it's valid,
Yeah, good point. Thank you. Let me see if there's any other questions before we let's see. Okay, ask this one. Can GERD-related chest pain result from taking a hot shower or soaking in a hot tub? Also, can stress cause GERD symptoms to worsen?
Yeah, I can't say that. I can't see any physiological change with taking a hot shower to make GERD worse, right? I mean, unless you're lying down in the bathtub, I could see that may make it worse. But just by the temperature of the shower, I don't see how that can make it worse. And the second question was what?
It was stress. Does stress cause GERD symptoms to worsen?
Yeah, I think stress is a very interesting thing in the GI tract. We've all felt that that feeling that if something really bad happens to you in your life, we all get that pit in the bottom of our stomach, right? I mean, where you kind of feel like your intestines tightening up. It's because the GI tract is very innervated by the nervous system. So whether or not stress itself is actually causing the reflux or it's heightening the sensation that you're having reflux, I think it's a hard thing to tell.
Yeah, perfect. Okay, so let's go ahead and talk about the different types of procedures or treatment options for GERD. So you kind of touched a little bit about the Nissen, that it's the old tried and the old school way of doing things, and there's a Latin Nissen now, and then maybe talk about the differences of all the different procedures that potentially someone with GERD could have.
Yeah,
including the TIF procedure.
Yeah. So I think one of the first things that we have to kind of educate people on is that if you have a hiatal hernia, you have to address that first. If somebody
can we explain what a hiatal hernia is? I think there's a big misconception what a hiatal hernia actually is.
That's a great point, because a lot of patients say, "Oh, I have a hiatal hernia," and they kind of point to their stomach. And so a hiatal hernia, your diaphragm separates your chest from your abdomen. It only has one hole in it, and that's your hiatus. And that's basically the hole that allows your esophagus, which is connecting your mouth to your stomach, go through into your belly, into your abdomen. And so your stomach should lie in your abdomen. It should be inside your abdomen. Your stomach being the reservoir that holds food, and your abdomen being your belly portion of your body. And so when you get a hiatal hernia, the hiatus is larger, and it can be from weight, it can be from diet, it can be from genetics, it can be from heavy lifting, it can be from millions of reasons. And as it gets bigger, well, then it starts to allow the stomach to go through the hiatus, and it starts to sit in the chest. And so your lower esophageal sphincter, which Dr. Thosani was talking about earlier, normally sits in the abdomen. and your abdomen has a bigger pressure. It sits at a different atmospheric pressure, and so it helps kind of have that sphincter be tight and closed. And the food is what's supposed to open that up, and then it closes again. But when that lower esophageal sphincter sits up in the chest, you got a lower atmospheric pressure to help you breathe, and then that lower esophageal sphincter doesn't work very well. So the food bolus can open it much easier, but at the same time, it sits at a much lower pressure, and so it lets a lot of stuff reflux. So if you have a hernia, we have to address that first, because whatever we do to the lower esophageal sphincter is not going to work, because it's going to be sitting in the chest and not going to work. So that's my main role, to be honest with you. When a patient comes to me, I tell them, look, I know we'll be able to help you. I know there's going to be something we can do for you, but it all centers around whether or not you have a hernia. Because if you don't have a hernia, there's either maybe other things going on or different kind of medications, or maybe you can just get, an endoscopic TIF by Dr. Thosani alone. So I really address the hiatal hernia at first. And so the hiatal hernia is bringing the stomach back down, closing the defect to the size of the esophagus, and basically recreating your natural born with anatomy. And so that's kind of step one for anybody with bad reflux. Then once we either know they don't have a hernia or we've fixed the hernia, then we have to do what's called an anti-reflux procedure. And there's lots of different anti-reflux procedures. Probably the four most common ones are some kind of external fundoplication, and that means where I wrap the stomach externally around itself, and that's either the Nissen fundoplication that a lot of people talk about, or the toupee fundoplication, which is a slightly looser wrap, and that's something that I can do as a surgeon. That's the one that's kind of been more around for a longer time, 25 plus years. It's still technically the gold standard, meaning that it's the more common one and the one that's most studied, but it really alters your anatomy. You have to take down a lot more of the stomach. I have to mobilize basically all of the stomach on the left and on the right side, and then I have to kind of wrap it around itself and create kind of this necktie, if you will, around the lower esophageal sphincter, because I can't fix the sphincter from the outside, so I have to kind of try to recreate it from the outside. People usually say that they eat smaller meals, they get full a lot faster, which some people may appreciate, but it still alters your anatomy and the way you eat. And a lot of people complain that they can't burp. When they feel full, they can't burp. When they feel sick, they feel like they're gagging and they can't vomit. So it is an altered anatomy. But it is something that we do all the time, and for the right person, it maybe is the right answer. And then the Lynx was created, and it's like these titanium metal beads. It's having an external foreign body in your around your esophagus, and it's supposed to recreate the sphincter again, because I can't fix the sphincter. It kind of recreates the sphincter and tries to work like the sphincter. But then you have a metal, there's some MRIs that you can't go through. There's some issues with having metal in your body. Sometimes it has to be removed. So it does have its known complications, but at the same time, for the right person, it could help. And then I think it's the TIF, and that's the transoral incisionless fundoplication. And the reason it's called fundoplication is because it's the same as the Nissen toupee that I can do, but from the inside.
Yeah, and it's actually it's quite a slick endoscopic procedure. It's one of these endoscopic devices that's really made well. And basically, what we do is we do an upper endoscopy that's that we have this device attached to, and when we go into the stomach and kind of flip our scope back up to look where the esophagus is coming in, we can see the laxity there. Right, we can actually see this hiatus and see that when the esophagus is coming through, it's not tight there. There's a laxity, and what we do with this is that we basically take the tissue and the muscle in the top of the stomach called the cardia, and we twist it on the inside, and we elongate it. So we twist and we elongate, and we create a valve there between, usually a 2 to 3 centimeter valve. And what that valve does, it kind of bulks up the bottom of that esophagus where it meets the stomach, and that valve makes things much tighter. It makes the sphincter work better, and it prevents acid from coming up. And the beauty of it is that the one thing is we definitely don't wrap as tight as something like the Nissen. The Nissen, it wraps 360 degrees around the esophagus. We usually get between 270 and 300 degrees around. And from an efficacy standpoint, it's still fantastic in decreasing the actual acid coming up. And that 81% of people in our long-term data, 81% of people in 5 years are still off of their proton pump inhibitors, versus I believe it's about 84 or 85% of people with Nissen. So it's comparable. It's a very good procedure. The beauty is, though, one, post-operatively, patients don't, I mean, they may have a little bit of soreness and a little bit of pain after, but it's usually short-lived. And patients don't have the same side effects that they do with the Nissen. When Dr. Amini, when he used to do a lot of these Nissens, I mean, patients would come in his office or call constantly saying, I can't burp, I have bloating, I still have pain, I have difficulty swallowing foods. And really with the TIF, that's actually the beauty of it. One, from an efficacy standpoint, but two is from it really takes away a lot of the symptoms that people have from the typical Nissen. So that's one major benefit of it.
And I think part of the issue with the Nissen and why some more patients complain about the Nissen postoperative than the TIF is because the Nissen really alters your, whereas the TIF does not alter your anatomy. It improves the sphincter and improves kind of that ability to tighten down on the muscle, but it doesn't alter your anatomy. The Nissen does a good job of preventing reflux, and that's why it works well, but it alters your anatomy. So sensations that are probably just related to the altered anatomy, like not being able to burp, feeling full sooner, feeling uncomfortable, having that pain, that discomfort, it's just because we've altered their anatomy. We fixed the reflux, but we've altered their anatomy. And you get much less dissection, you get much less inflammatory response from my surgery when I only have to fix the hiatus and Dr. Thosani can do the fundoplication internally or transorally.
Perfect. Yeah, thank you. So we do have quite a few questions, but before we do that, can we talk a little bit about recovery from obviously both hiatal hernia and then the other question that always comes up is what percentage of your patients have a hiatal hernia? Is it with majority of them, if they're having reflux, majority of them have a hiatal hernia as well, or?
Yeah, I would say the majority of the patients do have a hiatal hernia. The question really is how big is it, right? And when we do an endoscopy and when we measure the hiatal hernia, we're basically trying to estimate how much of that stomach is up in the chest. And if it's less than 2 centimeters, it's something we can fix without needing any kind of surgery, because I can pull the esophagus and pull the stomach down in the chest a little bit, a couple centimeters. If it's more than that, really, patients are going to do better having a surgical repair of their hernia, and then after that, what we do is at the same time he does the hernia repair, and then right when he's done, he closes the abdomen, and then I do the endoscopy. So we do it all in one shot. So really, it depends on the size of the hiatal hernia. The recovery from the procedure, if I can do it completely endoscopic, the majority of my patients go home the same day. Some people have a little more pain, and they're just not doing as well because of pain issues or inflammation afterwards, and I'll keep them in the hospital overnight. But the majority of my patients that we do completely endoscopically go home the same day. When we do it jointly, when we do a surgical hernia repair and then an endoscopic fundoplication, we normally keep the patients overnight. And that's because they are having a surgery. Dr. Amini is doing them robotically, which is great. It's minimal. They still have little incision ports, and I think it's very nice to watch them and control pain or control symptoms for one night, and then after that, their patients are really doing well.
The recovery is outside of the 1 day in the hospital. The recovery is really quick. At 2 weeks, when they come and see us, other than the diet, we put them on a diet afterwards. Other than the diet, most patients have minimal complaints. None of our patients where they're taking pain meds after day 1, day 2, they're pretty much back to work 3-4 days after surgery. At 2 weeks, it's really just kind of talking about the diet and getting through the diet, the diet post-operatively.
Yeah, and I think that's probably the hardest thing of any kind of, whether it's endoscopic or surgical repair to a hernia, whether you're doing a Nissen or a toupee or a TIF. I think the hardest part is the post-operative diet, because what we actually ask patients to do is to be on liquids. I mean, and it's really strict liquids for anywhere from 3 to 14 days afterwards. And then you can start to advance your diet. So and the reason you don't want to deviate from that is because you don't want to have anything stretch out the repair. And if it's a TIF, you don't want to have break any of the plications, or if he does a surgical repair like a Nissen, you don't want it to loosen up or unwrap. It's probably not going to happen, but you don't want to put a lot of solid food in there. So I think that's probably the hardest thing that our patients have to deal with.
Some people find it, they lose a little bit of weight, and they don't. Some people, they can't stand it, but it's not that bad.
Yeah, until they can eat normal again. It's like, food. So there is a question about how long will they need to wait until they can exercise after the TIF procedure?
Again, if it's a straight TIF, I have to be honest, I don't know exactly what the literature says from the company standpoint, but I usually tell patients to wait about a week. And to be honest with you, there's not a whole lot if it's a straight endoscopic TIF that you're going to disrupt in there. Even if you exercise a little bit, it's not like any kind of torquing motion is going to change what we did in there. But you are going to have some inflammation. You're just not going to feel 100%. I usually tell patients to wait about a week. But if you have the surgical, it's
the only thing. Yeah. The only thing I would add, 1 to 2, if it's surgery, then I'm fixing your hernia and we're doing a little bit more, 1 to 2 weeks to kind of a lot of exercise, but then 4 weeks, no heavy lifting.
Yeah. Okay.
And heavy lifting would be like 15 pounds. Yeah.
Okay. Perfect. So let's get to some questions here. How safe is it to have a procedure in today's environment? I'm assuming they're talking about COVID. Deductibles are met, and wondering if still time to schedule and get it done before the end of the year.
Yeah, the COVID issue. I mean, I think it all depends on tolerances. I can say that in our hospital that we work at, I mean, there are currently today, there's very few COVID cases. Every single one of our patients has to have a COVID test before they walk into the hospital. Every staff member is thoroughly washing their hands, wearing gloves. Everyone must wear a mask, and whether it's done in the endoscopy suite or in the operating room, it's all standard precautions. So I think I'm actually less, and we're both in the hospital all day, every day, and I'm actually not worried about contracting COVID in the hospital. But it all depends on what your risk tolerance is. I'd say if you have other comorbid medical conditions and you're on the elderly side, you may want to think twice about it and just wait, because nothing here this is not an emergent procedure. This is an elective procedure. But I think if I don't have any hesitation to bring a patient in right now.
There's been no surgical patients that have gotten COVID in the hospital. That's one. And then 2, I think the surgery patients, you basically go into the pre-op area, you see the OR, you go to the recovery area, and you go, to your room and then home. So you don't really see a lot of the hospital or do a lot in the hospital. I mean, I agree with Dr. Thosani. I really don't see an issue unless you're extremely risk averse or you're high risk.
Yeah. Perfect. So Abby's asking, does PPI change the chemistry of your stomach totally, or it just suppresses the acid until it wears off?
By the chemistry, I think what it does, it changes the acid content. So yeah, it's changing the chemistry of the secreted material in the stomach, and it's a temporary fix. meaning so your body generates these proton pump inhibitors every whatever it is, 24 hours, 18 hours. So when you take the PPI and the drug attaches itself to these proton pump inhibitors, it basically kills those pumps. But the pumps come back. 24 hours, they're back, and that's why you can't just. That's why you have to take this medication once a day to twice a day to keep the acid suppression down.
And that's also why it takes like a couple of days to start working, and then when you turn it off after a couple of days, it stops working also. So it's not a permanent change to your anatomy.
Okay. James is asking, what should a person do once the problem is so bad? And I think it was when you were talking about, after having the Nissen, when a person is gagging because they can't get that bubble up and they can't burn, they've had the procedure. Yeah.
This is after a Nissen?
Probably that's when the question popped up. Yeah.
Yeah.
So.
Yeah. I mean, there's not a whole lot to do with that. It's time, and the gas bubble will eventually dissipate. And it can be very uncomfortable. And as Dr. Amini will tell you, some of the Nissens he's done, I'm sure, some of the patients of mine that have had Nissens in the past, they call me and they're almost frantic because you feel like you just can't get anything up. So it's a problem. There's really not an immediate fix. I usually tell patients to take Gas X, see if we can break the big gas bubble to smaller bubbles, and sometimes it's effective, but yeah, there's not a whole lot you can do other than waiting and giving it time.
And that's the issue with the Nissen. With some people, the Nissen works awesome, and they really don't have a lot of issues. And with some people, it doesn't work well, and you really don't have a lot of options other than medications. And if you start down that path, then you're almost back to pre-Nissen state, right? Okay, well, change your diet, add these medications. I was like, well, wait, before the Nissen, it was change my diet and add these medications. I'm kind of back in the same boat. But other than potentially evaluating their anatomy, making sure that there's nothing wrong with the Nissen, make sure that the Nissen didn't slip or that there's any new anatomical things that can be surgically fixed, it's going to be kind of managing it with a GI doctor.
Yeah, and the one thing that I do want to clarify here is that, I mean, the Nissen is still the gold standard in terms of acid reflux, and it does work. I mean, it does work well in many patients. And it's not like all patients have side effects, but it's a good proportion. I'd say. I think it's about 25% of patients have side effects after a Nissen. So, but in terms of a Nissen working to keep the acid down, it does. It works fantastic. But you have to be willing to have a potential for the side effects, and I think that's really where the TIF is making great strides. Is that the long-term data is showing it's as effective as a Nissen, and if you can have something that's as effective and decreasing those side effects, I think that's.
And you haven't burned any bridges either by doing it.
Yeah, that's true. After you do a TIF, if it doesn't work, you can always go back and have a Nissen. And vice versa too. Actually, we've actually done patients that have had a Nissen and a hernia repair, and the hernia slipped, and he goes back to fix the hernia, and I'll go back and I can actually tighten the area around the Nissen. I think we've done it. We did one our last session actually. So so there's options.
Okay, that's great. Okay, more questions. Abby's asking, can endoscopy cause the stomach bulb, I'm assuming she's saying the stomach, to be damaged, say accidentally?
Yeah, so that's a good question. So from an endoscopic standpoint, I think the most challenging part about the TIF is actually getting the device down the esophagus. Because of the nature of what we're doing, we have the device is about 20 millimeters or 2 centimeters wide. And we have to be able to pass this device down through the esophagus. And there are, without a doubt, there's times where we can cause what's called superficial tears in the esophagus, which the vast majority of the time, if they happen, it's not a big issue. It's very superficial. But I think that to me is the biggest challenge of the procedure is taking our time esophagus and getting that device down. Once you're in the stomach, honestly, it's very hard to damage the stomach. The stomach is such a tough organ. It takes a lot to damage damage the stomach. My concern is always the esophagus, and just that first 10 minutes or 5 minutes of the procedure, getting that device down is, to me, where you have to be very careful and proceed cautiously.
Perfect. Thank you. So Colt is asking, is probiotic okay for GERD?
There's actually not a lot of data on probiotics. I know people have been taking them for all kinds of issues, but when you really look at what the indication of probiotics for, there's really only one GI indication that it's shown to be beneficial, and that's in preventing diarrhea when someone is on antibiotics. That's the only condition that a probiotic is actually studied for and is proven to help. When I talk to patients, some of them swear by probiotics. It helps everything, the way they feel, or pain, or diarrhea, or constipation, or I can't see any physiological improvement in GERD with the probiotic, because again, GERD is an anatomic issue. It's an anatomic issue that we have gotten into a pattern of treating medically. So I don't want to say 100% it's not going to help, but I don't see a way that it would help.
Perfect. Okay, like 2 more questions. Sandra's saying she's 9 months post-surgery, TIF surgery. I'm having so much mucus in the back of my throat, I cannot cough it up. It causes me to gag. Is that normal?
That's unusual.
Okay.
I'm wondering if she's still feeling acid reflux. Is she still actually having symptoms of reflux? If the TIF didn't work great, and still having acid reflux, it could cause some irritation in the back of the throat. It can go down into the trachea and cause an inflammatory reaction, causing mucus. But it's a hard thing to say now, is that causing the mucus? And if she were my patient, or if she would come to see me, what I would do is actually recommend doing another endoscopy and putting in what's called a pH probe or a Bravo probe to see, is she really refluxing?
Yeah.
And if she's refluxing, I think it's worth going down that route, that the mucus could be caused from reflux. But if that test shows that she's not refluxing, there's multiple other things that can cause mucus, chronic sinus infections, some different lung issues. So I think that would be that would need more of a workup.
Okay, perfect. Okay, one last question. How about the case of decreased pH level in the stomach that could be the main cause for a relaxed LES, hence resulting to reflux?
Is that with the medications, with proton pump inhibitors?
Yeah, that's a good question. I'm assuming they're saying decreased pH level in the stomach, probably from PPIs.
So
does that cause a relaxed LES?
All right. So when you take a PPI, it actually increases your pH level. So it makes it less acidic. Less acidic means a higher pH, right? So when you take a PPI, it makes that pH level higher. I don't think that in and of itself weakens the lower esophageal sphincter. I mean, there's a lot of things that presumably do weaken it. Pregnancy, with all the hormones, it can loosen the lower esophageal sphincter. Caffeine can. There's studies that show caffeine can, chocolate can, and that can lower the sphincter pressure. But I don't think the sphincter pressure is directly related to the actual acid content, either too much acid or too little acid in the stomach.
Okay, perfect. Thank you. Well, so that's all the questions. I mean, let me double check. Yeah, that's all the questions we have tonight. But I do want you to talk a little bit about your practice. Tell us where you guys are located. If a patient is in, you guys are in not Phoenix, Scottsdale, Arizona area. Well, Phoenix, Scottsdale, kind of the same.
We cover all.
Yeah, just let everybody know a little bit about your practice and how they can reach you if they want to schedule an appointment with you guys. for initial consult?
I'm the surgeon, Dr. Amini, and I'm with Arizona Premier Surgery. It's actually pretty easy. It's just arizonapremiersurgery.com, all spelled out. And there you can see kind of my profile, things about GERD and reflux and the procedures that we do. And I think if you're been on PPIs for a while or on medications for a while and you've been suffering for a while, I think it is reasonable to start getting a better workup and seeing what other options there are. And then Dr. Thosani.
Yeah, so my practice, at least my office is in Scottsdale. It's through the Honor Health system at the Shea Hospital, which is on the corner of the 101 and Shea. If you go onto the Honor Health website and type in my name, it'll come up. And yeah, but we treat both of us actually treat patients throughout the valley. Whether it's Phoenix or Chandler or so.
And that's a good point, because our practice has 3 offices, so we're out of Chandler, Gilbert. We cover the East Valley, we cover the West Valley, we cover Scottsdale, so we're kind of all over. And I think if their symptoms are mild, they're really not on medications, they can control it with some diet changes, then they're probably doing pretty good. But if they've been on PPIs for a long time, more than 6, 9, 12 months, they're still not comfortable. They haven't gotten a workup. They need at least some stuff, endoscopy, upper GI, a couple things to start to see, is this an anatomical problem, which we've clearly described and defined, and that would need something better than medications.
Yeah, and the one thing that I do want to stress, right, is we have to understand that acid reflux is not just a problem with how you feel. It just it's not just a symptomatic problem, but the real problem with acid reflux is that if you have chronic acid reflux, you can get something called Barrett's esophagus, and Barrett's esophagus is the precursor to esophageal cancer, to one type of esophageal cancer called esophageal adenocarcinoma. And the symptoms are important. It affects your day-to-day life, but the real problem is having the reflux cause this precancerous and then cancerous change. And a good part of my practice is I actually take care of a lot of folks with esophageal cancers, and you need to prevent this, right? I think that's one of the biggest things. It's not just how you feel, but it's really about preventing the progression of Barrett's esophagus. So that's why having some kind of anti-reflux mechanism is important.
Yeah, perfect. Yeah, and that's at the end of the day, the whole reason why we have the TIF Talks is to educate these patients that are watching, or patients that are concerned if they've been on PPIs for so long. There are options out there, and that's really our goal, is to let them know there are options out there. They don't have to keep suffering, and to advocate for themselves. So we really appreciate you both being on here tonight and discussing GERD and all of the treatment options and the TIF procedure, obviously. So any last thoughts that you want to share with everybody that's watching before we end for the evening?
No, I think I think the last statement that you said is extremely important. I think patients have to take this very seriously. Right? I mean, it's a chronic problem that you feel every day, but you don't want to let it go. You at least get somewhat of a workup, see a gastroenterologist, or a surgeon or something, and just make sure it's something. It's not something more than just mild reflux.
Dr. Amini, anything else you want to add? No, I think we've covered it all. I think this is helpful. I think this is great, and I'll echo what everybody else has said. I really think if you've only kind of briefly gotten a prescription for a PPI or an H2 blocker, or you've picked it up yourself, I really don't think that's enough, and that's not your treatment for the rest of your life. And I think things like this, and educating yourself and getting further specialty people to kind of overlook everything is what you need going forward.
Perfect. Wonderful. Well, thank you again, doctors, for joining us this evening. And everybody that's watching, thank you for joining us. If you're in the Scottsdale area or Phoenix or anywhere around there, you can go see Dr. Thosani and Dr. Amini and schedule an appointment for an initial consult. If you're not around the area and you're looking for a physician in your area, you can go to gerdhelp.com. And on there's a physician finder, and you'd be able to put your zip code and find a physician that's in your area that does the TIF procedure. So again, thank you very much, Dr. Thosani, Dr. Amini. Everybody, have a great evening, and thank you for joining us. Have a good one.
Thank
you
you
for having us.
Thank you.